All right. So, good morning. My name is Cecilia Giulivi. I'm a professor at the University of California, Davis, and I'm going to present this study entitled Maternal Plasma and Metabolomic, the market role for neuroinflammation in non-typically developing children. And we published this study, and the co-authors of this study are Rebecca Smith, Dong Hai Liang, Stephanie Busman, and Paul Frick. So what gap in knowledge we were trying to fill? So clinical diagnosis of autism on non-typically developing children is not made until overt neurological symptoms. And the gold standard right now is 36. So we need an immediate need for early detection of processes that alter and could be used as markers for the risk and to potentially inform effective interventions to allow them to develop their lives to their fullest. So to address this gap, we turn to metabolic profiling offered by this wonderful CHEAR program of readily accessible fluids to study what metabolic pathways were altered, if any, between children with a diagnosis with autism versus typically developing or non-typically developing, to typically develop. So for that, we use an untargeted metabolome approach from using third trimester maternal plasma and umbilical cord from these pregnancies. And then we took the diagnosis that these babies had when they were grown up to 36 months with the diagnosis of autism or not typical development. And this group is a high-risk group because these mothers were recruited with a prereq that before they had a previous child with autism. The children were clinically classified as in either diagnosis based on ADOS, standardized instruments, ADOS and NSEL. And then we use the metabolome wide association approach to assess single metabolites with dimensionality reduction techniques such as PCA and a random success implementation of weight quantiles and regression because we had a ton of metabolites versus a limited number of participants. So the participants were taken from this huge study called MARBLE, which are the markers of autism risk in babies learning early time, that we call it in the house MARBLE. And this is the first epidemiologic cohort of study of younger children, younger siblings of children with autism, and we enroll the mothers prenatally. The idea is to capture exposures and specimens when ASD is likely to originate early in development. So the overarching goal of MARBLE is to uncover environmental and etiological agents contributing to autism and investigate their mechanisms of action and identify early biological markers of risk. So younger siblings at the familial, at the high family risk for autism is 1 in 4 versus 1 in 44. So we have 10 times the risk. So this population is enriched for children with autism or with non-typical development. And all the samples and subjects were taken from the Northern California region, about 2 hours away from the mining. So the MARBLE protocol, we published it before. So here's the paper. Essentially, during the pregnancy, we give the mother questionnaires, interviews, medical records. When the child is born, we take biological samples. Also, we take biological samples during pregnancy as well as environmental samples. And then finally, at 36 months, we do parent polls and clinical assessments for diagnosis of autism, anxiety, whatever. So this is the demographics of the cohort that we did the metabolomic, and we have here non-TD, autism, and typically developing. So we have non-TD about 27 children, ASD 57, And from all the demographic data that we collected, only 3 were significantly different, and that was the child sex, which was biased towards more males than females. And we know that the incidence of autism is higher in males and females. Then the gestational age of delivery, which seems to be larger, bigger, longer for non-TD and ASD. And then finally, the maternal BMI before the pregnancy, which women seem to be having higher BMI than women that had a normal time. So approach and results with the full set in regards to autism. So participants missing any of the covariates or final outcomes were removed. We only took metabolic pictures that had above 80% detection, and then we did an MWAS type analysis to evaluate the associations between intensity of each metabolic picture and diagnosis status. And also we corrected for multiple comparisons. We use, as I told you before, PCA as well as other type of analysis. Metabolites identified in the positive and or negative mode of maternal plasma and cord blood, several were significant for autism risk, but not one of them was annotated. So their present biological significance remains unknown. For results with the annotated only set for autism risk, none of the annotated metabolites, again, was significantly associated with risk of ASD diagnosis after the false discovery rate as correction. 4 maternal metabolites were mostly associated with increased autism risk, and those were phosphoetanolamine, indole, beta-in, and serine. And all 4 were also in pathways previously implicated in ASD etiology. However, none of these 4 fit in a single pathway. So the biological significance is still unknown. Acetylcarnitine was one of the most associated with maternal single metabolites for non-TD, the positive mode, and also has been previously identified as a metabolic marker of autism. But please keep in mind that none of this was significant after SDR correction. Now, if we look at the data for the non-TD risk, there were several that were significant after SDR, and I put them in 2 categories. So one is the green, palmitic acid, palmitoleic acid, myristic acid, stearic acid, and then the other one, docosahexaenoic acid, gamma-linoleic acid, and linoleic acid. And we're going to see why that is the case. So fortunately, these were annotated, and they fell within pathways. So it was easier to do some kind of biological conclusion for this. When we ran the metabolites, most of them, oh, sorry, I lost my, here it is. Mostly fell into the alanine, linoleic acid metabolism, fatty acid biosynthesis, glycolipid metabolism, as well as mitochondrial detoxidation of long-chain saturated fatty acids. When we did the metabolite disease network analysis, these metabolites were associated with schizophrenia. Let's remember that autism back then was called infantile schizophrenia, hypertension, stroke ischemia, and isovaleric acidemia. What is interesting is that the odds ratio was higher of having a child with a diagnosis of non-TD with those pathways that are more, they have a higher flux through prostaglandins and thromboxanes that are pro-inflammatory. There are 2 pathways. One is through the N3 polyunsaturated fatty acids, the other one is through N6. The ones that are coming out, prostaglandins from the N6, seem to be more pro-inflammatory than the ones under the N3. because the N3 also gives rise to resolving, protecting, and NDPA, which are a little bit, they are quite a bit protective. However, the increased risk for non-CD diagnosis seem to be associated with an increase of this pathway, the N6 polyunsaturated fatty acid. So the N3 foster neuronal activity and counteract extended memory deficit in mice, enhance mitochondrial dysfunction, increase the expression of glucose transporters, ameliorate spatial memory in rats, increase the expression of transcription factors involved in learning and memory, and increase brain function and decrease tau phosphorylation in a mouse model of Alzheimer's. So there's plenty of evidence out there indicating that if there is an imbalance between N6 and N3, we do have neurodevelopmental as well as neurodegeneration. Now, if we go back to the fatty acids I highlighted there that are not within the N3 or N6 pathway, then those were myristic acid, palmitic and stearic acid, and palmitoleic acid with lower in non-TD diagnosis. And this is important to remember that axonogenesis requires de novo synthesis of monosaturated fatty acids, such as palmitoleic acid, based on the evidence that BDNF promotes both axonogenesis during brain development as well as fatty acid oxidation. So both of these, the metabolome percent, we had two conclusions. One, that maternal plasma had more neuroinflammatory biomarkers in those women that then they had children with a non-TB diagnosis. And also with this, having lower of these, or these fatty acids were also increased with higher risk for, actually lower content of this was increased with a higher. So inflammatory mediators can alter critical functions of neurons and glia directly. Remember that this is peripheral biomarkers, so we don't know what is happening in the brain of the child, but apparently there is correlation with that. And they also may affect the selective permeability of the blood-brain barrier, providing a mechanistic link to alter brain development, as well as the occurrence of epilepsy in autism. If we have maybe these fatty acids were originated from the fetus, which we don't know, maybe there is some issues with the permeability of the blood-brain barrier. Appropriate interventions that control immune responses during pregnancy may have a positive impact at decreasing the non-TD and ASD diagnosis risk. So CHEAR and CHEAR considerations, the challenges were that funded projects were a priority. We had very limited extra manpower for pulling the specimens and preparing data sets and data dictionaries, so delay in the project start. The R24 grant that we got helped with this aspect, and then limiting interaction between basic science and statistical analysis, which could have taken the analysis in a different direction format. The strength is provides interesting findings with measures that would not otherwise have been possible. The CHEAR team was very responsive and helpful to have assistance with the analysis. Funding support, we got to always NIH, CPA, UCD, Mind Institute, and different funding sources, but none of them actually has a clear metabolomic focus as the CHEAR provider. So that's all. Thank you very much for your attention.